Hello. This next talk will be on CT of the colon. And specifically, I'm going to talk about CT of colitis and also a little bit about CT of diverticulitis. So beginning with CT of colitis, I would ask you all if you have ever dictated something to the effect of there's thickening of the wall of the colon, which is nonspecific. It may be infectious or inflammatory in etiology, less likely ischemic. This is pretty common verbiage that we often put into our reports that reflects the fact that oftentimes when we make a diagnosis of colitis at CT, it is pretty nonspecific looking. However, there are signs and distribution of disease that can help differentiate between etiologies. So today we're going to talk a little bit about what those are, and conversely, when is colitis truly nonspecific? When do we have to just give the entire differential? So there are a couple of ways to approach this. Number one, you want to look at the appearance of the colon. Number two, the distribution of the abnormality that you're seeing in the colon. And number three, something very simple, you want to look for the presence or absence of ascites. And while we're doing these, this image interpretation, at the same time, we also want to keep in mind the patient's age and the duration of their symptoms, because this can help guide us towards different diagnoses as well. And lastly, if the patients have any other signs at imaging of systemic disease. So we're going to start with inflammatory bowel disease, and we're going to go through each of these features to try and determine what makes a diagnosis of inflammatory bowel disease specific. So starting with appearance of the colon. When you're looking at a case of suspected inflammatory bowel disease, what you really want to find is evidence of both acute and chronic inflammation in the same patient at the same time. So let's review what those signs are. Signs of acute inflammation. Number one, pericolonic fat stranding. Number two, wall edema, sometimes called the water halo sign or the target sign. We'll take a look at that. And then mucosal hyperenhancement. Chronic findings that we can look for are fibrosis. And fibrosis can manifest in several different ways in the colon. You can either see focal stricture or a lead pipe or ahaustral appearance of the colon, both signs of fibrosis. You can see mural fat. That's sort of the counterpart to mural edema. That is sometimes known as the fat halo sign. And then also inflammatory pseudopolyps are a sign of chronic inflammation. So let's take a look at each of those. So starting with acute inflammation, here a nice example of pericolonic fat stranding surrounding the descending colon, very abundant fat stranding in this case, a clear sign of acute inflammation. Now the water halo sign or the target sign, I'm of course referring to that hyperdense, hypodense, hyperdense layering of the bowel wall, demonstrated by this little donut graphic to the side. That is a sign of wall edema. If you see that, it is acute inflammation. And then lastly, mucosal hyperenhancement. This tends to be one of the most noticeable features, I think, in abnormal colon at CT, assuming you've given IV contrast. It really stands out and leads your eye to the abnormal segment of bowel, this mucosal hyperenhancement. Now, that is only the case if you have not given positive oral contrast. So this is the same patient, IV contrast only on one image, IV and oral contrast on the other. And you notice that that positive contrast is exactly the same density as the mucosal hyperenhancement. It completely masks it, masking an important sign of acute inflammation. And this is why we do not give positive oral contrast in any of our cases where we're worried about acute abdominal pain. The fat halo sign, so getting into the chronic signs. So here we again see that stratification of bowel wall, so that hyperdense, hypodense, hyperdense layered appearance. But the low density here, that inner layer of the bowel wall, is fat density instead of being water. It's not edema, it's fat. This is a sign of chronic inflammation. We see it nicely here in the rectum, clear layering, very noticeably fat density when we compare it to the adjacent mesorectal fat. Now you can see the fat halo sign in normal patients, and these are two examples of patients who did not have inflammatory bowel disease and did not have chronic inflammation, but we see that same layered appearance with fat in the bowel wall. You see this more commonly in patients who are obese compared to thinner patients, and you see it more commonly when the colon is collapsed. Same goes for small bowel if you're looking for the fat halo sign in small bowel. If you see fat in the bowel wall when the bowel loop, the colon loop, is distended, that is more indicative of pathology. Fibrosis, one of the chronic findings. So here we see an example of stricture, two examples of stricture in the colon due to chronic inflammation and fibrosis. Another example, sometimes this is something that residents will often ask, how do you tell if an area of narrowing, maybe with associated obstruction, is due to stricture or edema of the wall? And sometimes it's both, and sometimes it can be hard to tell. Here's an example where there probably is some underlying fibrosis and stricture, but the wall is very thick and looks stratified, and there's probably some edema here as well. And often, times when these patients are treated and the acute edema resolves, sometimes the obstruction can resolve a bit as well. Now, this is supposed to be a talk pretty much about CT of the colon, but just a quick nod to MR because it can be useful here in some ways that CT is not. If you're trying to differentiate between whether a narrowed area is due to fibrosis or acute edema, MR can actually help with that. If you look at the T2 weighted images, fibrosis tends to lead to a T2 dark wall. Edema is going to be T2 bright. So if you're looking at a Crohn's patient and you've done an MR enterography as opposed to a CT, this is one benefit of MR in that scenario. The other appearance of chronic fibrosis, chronic inflammation in the colon, the ahaustral colon. This was a patient with ulcerative colitis. And then our last sign of chronic inflammation, pseudopolyps. Now, this is something that people tend to think of more as being an old barium enema finding, but you can actually see it at CT as well. Here we see these little heaped up bits of enhancement along the mucosa. Pseudopolyps, a sign of chronic inflammation. Now here, the sort of perfect diagnostic image, we have evidence of acute and chronic inflammation in the same patient on the same image, thickened colon, pericolonic fat stranding, and we have there. And then we have down in the rectum evidence of a fat halo sign or chronic inflammation. This is highly suspicious for inflammatory bowel disease, acute and chronic inflammation together. Distribution of abnormality can also be helpful. So in Crohn's disease, we expect to see abnormalities that are segmental, that skip areas. It tends to be predominantly right-sided, and we, of course, can see small bowel involvement. Also, I think this gets a little bit less attention and is actually one of the most useful distribution signs. Crohn's disease tends to involve bowel eccentrically, and I'll tell you what I mean by that in a moment. By contrast, ulcerative colitis is sort of the opposite in all of these distribution points. Distribution tends to be diffuse rather than segmental. It's predominantly left-sided, starting with continuous retrograde progression from the rectum. We should not see small bowel involvement unless there's a little bit of terminal ileal involvement due to backwash ileitis. and it tends to involve bowel loops circumferentially rather than eccentrically. So looking at some of those examples. So here we have diffuse colitis that started, we see it involving the rectum, it involves the left colon, it involves the right colon as well. When it's diffuse, it's hard to differentiate between Crohn's and ulcerative colitis because both can conceivably do this. If it's skipped, you would think more about Crohn's. This could be both, and this did turn out to be Crohn's. Here, a case that was clearly Crohn's because we saw segmental involvement. It was predominantly right-sided. There was some involved small bowel as well, and we saw segments of normal colon intervening between segments of abnormal colon. So distribution suggestive of Crohn's disease. Now, this is an example of what I was talking about with eccentric involvement of the bowel wall. If we look at the right colon here, you see that the medial wall of the colon, where that arrow is much more thick, almost mass-like compared to the more lateral wall adjacent to the liver. That type of eccentric involvement is extremely characteristic of Crohn's disease. And if I compare it on this slide to a case of ulcerative colitis, I think it really stands out that the ulcerative colitis, the loop is very circumferentially evenly involved. Crohn's disease tends to be more eccentric. I find this to be one of the easiest ways to tell Crohn's versus ulcerative colitis apart. Here, another nice example of Crohn's disease. If you look at that posterior wall, much more thickened, also kind of nodular looking compared to the anterior wall. You're not going to see this in ulcerative colitis. This is highly suggestive of Crohn's disease in a patient where inflammatory bowel disease is suspected. And then lastly, presence or absence of ascites, such an easy thing to look for. If you sort of look back among some of these images I've already shown you, like this one, it's actually quite notable in these inflammatory bowel disease patients that they will sometimes have very severe colitis like we see here, but a really striking absence of ascites. Now, if you saw a colon that looked like this that was due to some sort of infectious colitis, the vast majority of patients are going to have some ascites, but in an inflammatory bowel disease, there's typically no ascites even when colon inflammation is severe. So this can be really useful in helping you to differentiate inflammatory bowel disease from other etiologies of colitis. Now with IBD in particular, since this is a systemic disease, you do want to look for some of those other signs of systemic disease to help you nail down the diagnosis if you're making a diagnosis of IBD for the first time. Here we see a patient with Crohn's disease with that marked terminal ileal inflammation noted by the arrow. They've also got sacroiliitis, fistula formation with abscess in the anterior abdominal wall, renal stones, and then a little bit of common bile duct wall enhancement, and pretty subtle but notable in a young person, central intrahepatic biliary ductal dilatation. Both of those, the biliary wall enhancement and the mild ductal dilation, are early signs of primary sclerosing cholangitis associated with IBD. So look for them in patients where you suspect IBD. So let's move on to infectious colitis and look at each of these imaging features again. So appearance of the colon, we will start with. And I'm going to talk about C. difficile colitis first, as opposed to just infectious colitis in general, because depending on your practice pattern, particularly if you're a resident in training in, a hospital setting, this is by far the most likely type of infectious colitis that you're going to see. So data shows that in C. difficile colitis, you're going to have wall thickening, not surprising, greater than 4 millimeters. So it doesn't have to be like striking wall thickening, but wall's a little bit thick. Pericolonic stranding. Colon wall nodularity has also been described. That's sometimes referred to as the accordion sign. And initially, when this was described, it was described as being very specific to C. difficile colitis. It's actually not, and you only see it in a percentage of cases. It's actually a minority of cases. What it indicates is severe inflammation. So we see it in the severe cases of C. difficile colitis, But you can also see it in severe inflammation of the colon due to other infectious agents or even things like Crohn's disease and so on. So it is not specific to C. diff. That said, because C. diff is so common, oftentimes when we see it, it does turn out to be C. diff. Also ascites, and of course, I mean, otherwise unexplained. So not a patient who has cirrhosis and portal hypertension, but you have ascites in about 50% of cases with positive C. diff. And of course, the more severe the inflammation is, the more likely you are to have associated ascites. So it turns out that in evaluating these patients, if you have colon wall thickening, and again, it does not have to be like marked thickening, just any amount of thickening, and any one of these other signs, so wall nodularity, pericolonic stranding, ascites, these are pretty nonspecific things all in all, so wall thickening and a little stranding or wall thickening and a little free fluid. The specificity for C. difficile is 93% in the appropriate clinical setting. So someone where you suspect colitis and they've just got a little bit of thickening and a little bit of ascites or a little bit of stranding, 93% of those are going to be C. difficile colitis. That just indicates to you how common of a disease this is. And it's why I'm talking about it first. Now, here's an example of that wall nodularity that I was talking about. So big sort of nodular thickening of the wall of the colon. Again, not specific for C. difficile colitis, but because it's so common, oftentimes when we see it, it's going to be in the severe cases of C. difficile colitis. This is kind of an example of the accordion sign where you see that thickened nodular appearance of the colon wall, and it sort of produces this interleaved appearance like the folds of an accordion. The true accordion sign referred to oral contrast or rectal contrast, but just luminal contrast getting in between those interstices here. This is just mucosal hyperenhancement, but leading to a similar appearance. The distribution of the abnormality. So in C. difficile, this can involve the entire colon, certainly. Infections can sort of do what they want. One point about distribution, though, that I think is important to us, in particular as radiologists, is that diarrhea can often be absent in cases where C. difficile is predominantly involving the right colon. So oftentimes if you get like a CT scan for something like right lower quadrant pain or fever, or, these sort of like vague things, and you see what looks like a right-sided colitis, you can suggest a diagnosis of C. diff, and they might say like, hey, it's, the patient doesn't have diarrhea. We don't really clinically suspect it, but these CT findings can precede diarrhea. So suggest it anyway. Very, very common in hospitalized patients. Here, a beautiful example of diffuse involvement of the colon in C. difficile with this gorgeous sort of nodular thickening, this accordion sign of the colon. Again, nodular thickening, not specific, indicates severe inflammation. This is a bad case. Presence or absence of ascites in C. difficile colitis, you're going to see it a lot. Here, big inflammation of the colon, it looks pretty severe, and we have ascites to go along with it. Now, how good is CT at making a diagnosis of C. difficile colitis? Because sometimes you'll get these CT scan recs that say something like diarrhea, rule out C. diff. That's not great practice. CT can miss 50% of cases prospectively. So like in early C. diff, you're not necessarily going to have abnormalities at CT yet. The worse off they are, the more severe the disease is, the more likely the scan is to be positive. And there's also some lack of correlation between CT findings and the clinical severity. There can be a bit of a lag. Sort of like chest x-ray and treating pneumonia where the patients may be starting to get clinically better and the CT still, looks pretty severe. So don't use CT to rule out the diagnosis. If you do see findings suggestive of it at CT, highly likely that you're looking at C. diff. Now, in terms of other infectious etiologies, other infectious agents that can involve the colon, this is an area where there aren't that many differentiating features. A lot of what you're going to look for is what I just talked about with C. diff, so wall thickening, pericolonic fat stranding, potential ascites. Distribution tends to be the most helpful. And there's this sort of old chart that we memorized at some point. I don't even remember if it was in medical school or residency at this point, but certain infectious agents tend to involve the right colon more so. So things like tuberculosis, Yersinia, Salmonella, amoebiasis, that sort of classic coning of the cecum. Common infectious agents like CMV or E. coli tend to produce a diffuse colitis. And then the things that have a predilection for the left colon, I find this list a little bit hard to remember, but it has some of the more infectious, some of the more sexually transmitted infectious agents, as well as Shigella and schistosomiasis. Here, an example of amoebiasis involving the right colon. It does tend to involve the right colon, but if you look at these findings, very nonspecific. So a little bit of wall thickening, a little bit of fat stranding around it. Most of the time when I see this, I'm going to assume that it's probably C. difficile, and I'm going to be right most of the time, but this was a case of amoebiasis. A case of tuberculosis. Don't see these too often. Not a ton that's specific here. Tuberculosis can actually look a lot like Crohn's disease. So we see severe inflammation of the right colon, thick wall, stranding around it. What's notable here is that there are some pretty big lymph nodes. Also, sometimes in tuberculosis, you can see associated peritoneal enhancement, and those features like really marked lymphadenopathy or associated peritoneal enhancement can raise the flag of TB if you have a patient that could have been exposed. Here, mystery case. We have a very thick-walled colon, very edematous-looking stranding around it. This patient had acute onset of diarrhea and fever. It was a diffuse colitis. So, possible diffuse agents, things like E. coli, CMV. Most of the time, I'm going to assume it's C. difficile colitis, but this was actually a patient who had had a bad hamburger, and this was a case of enterohemorrhagic E. coli. Another mystery case. This was a 12-year-old with leukemia and diffuse colitis. Differential here for diffuse colitis. Again, CMV. We're always going to put C. difficile on the list. Probably less likely to phlitis here because it's not just involving the right colon. It's a little bit more diffuse than that. But this turned out to be C. difficile colitis. Often the answer. And then lastly, let's talk about ischemic colitis and how we can tease that diagnosis out from IBD or infectious colitis. So again, starting with the appearance of the colon. Things we can look for here. This one is a little bit different than the previous colitides I've talked about in that you don't necessarily have wall thickening at all. So sometimes in ischemic colitis, you will have a thick wall, but sometimes the wall will actually be quite thin. Because we're talking about ischemia here, we can look for an enhancement abnormality where I don't necessarily mean hyperemia, but hypoenhancement of the colon wall. We can also look for colon distension and then pneumatosis, which of course can be a quite specific feature of colon ischemia. So let's look at some of those examples. Here, an example of ischemic colitis where the wall is very, very thin. This is, clearly ischemic colitis. We have pneumatosis and then air in the mesenteric veins as well. But note how thin the wall is here. The wall is actually almost imperceptible. And this can be seen in the setting of ischemic colitis. On the other side of the screen, we have an example of a very thick-walled colon. That is also quite classic for ischemic colitis. So we can have the two appearances when it's thin-walled, particularly in a case like this, where we see evidence of pneumatosis and portal venous gas. the diagnosis is more obvious. But in these thick-walled cases, it can have quite an overlap in the spectrum of appearances with infectious or IBD type colitis. So I'm going to talk for a few moments about how we can try and differentiate a thick-walled colon in ischemic colitis from cases of IBD or infectious colitis. Now, when you are looking at a thick-walled colon in ischemic colitis, usually that's going to indicate a venous etiology of the ischemia as opposed to arterial in the thin-walled cases. So here, an example of ischemic colitis with wall thickening that would be pretty hard to differentiate between a case of colon infection and colon ischemia. So the wall looks thick. It also looks a little bit stratified. There's some edema of the wall, and there's pericolonic stranding around it. You're actually going to see this thick-walled appearance with stranding and stratification in the majority of patients with ischemic colitis. This is sometimes referred to as the wet appearance of ischemic colitis, and this is reasonably nonspecific all by itself. You see the stranding there. Here we're helped out that there was a classic distribution with small bowel involvement. This patient had an SMB thrombosis. Now there's an alternate appearance for ischemic colitis where you see a uniformly hypodense wall like we have here. It does not look stratified or edematous. It just looks uniformly hypodense. And there is no pericolonic fat stranding. In fact, if you look at the sort of outer margin of the bowel wall here, there's this very crisp demarcation between the thickened colon wall and the very normal looking fat around it. This pattern is seen in about a third of cases of ischemic colitis, and it is sometimes referred to as the dry appearance of ischemic colitis. The reason it looks hypodense in this case, of course, is that it is not enhancing well due to the ischemia. Bowel dilation. This tends to be pretty uncommon in infection outside the circumstance of toxic megacolon, uncommon in IBD unless there's a associated stricture or something. So most of the time when you see bowel dilation, you want to be thinking about ischemia. And then pneumatosis. So this is certainly specific for ischemia when we see it. You just want to be confident that what you're looking at is actually pneumatosis. So here we see these sort of bubbly bits of gas within the wall of the colon. This was a patient who had an aortic dissection, which continued into the SMA. But what about this? This is a case of what we sometimes call pseudopneumatosis, or two cases of pseudopneumatosis. These were two different patients, where it looks a lot like there is gas in the wall of the colon. But what's actually going on here is that there is sort of bubbly stool in the lumen, and there's actually just air trapped between the colon wall and the bowel contents. And one of the ways you can tell the difference is to go up and look at the non-dependent wall and see if you see continuation of that sort of bubbly wall abnormality where you are no longer seeing stool in the lumen. And you notice that, it looks funny here, looks funny here, looks funny here, and then all of a sudden it looks very normal. So this is not true pneumatosis. So here an example of true pneumatosis where we look at the non-dependent wall. We look at the lumen is quite full here, so hard to tell. But these cases where the lumen is outlined by air, we're still seeing those dots of air in the non-dependent wall. This is actual air in the wall, true pneumatosis. Also, if you see a linear appearance of gas, that is a more ominous sign, a better sign of true pneumatosis than the bubbly appearance, which is sometimes more easily mimicked by stool. Here you'll note that this sort of linear gas-like appearance does look like it's sort of disappearing once we get to the air-filled part of the lumen, but that's just due to windowing here. If we put this to more of a lung window, you would be able to see the air continuing into that non-dependent wall. So when you're looking for that, that's an important trick. And then this is sort of like the sine qua non of pneumatosis, where you're not only seeing gas in the non-dependent wall, but you're actually seeing mucosa dissected away from the wall. So really striking pneumatosis of the colon here. Now, using these signs, we're sometimes asked to differentiate ischemic bowel and infarcted bowel. Is this bowel infarcted? Is it dead? Do we have to go to the OR? And the answer is that we can't reliably tell the difference. Pore enhancement is not a great discriminator in the colon. In small bowel, when you see non-enhancing small bowel, that has a very high correlation with dead bowel at surgery. But you'll often have pore enhancement of the colon in reversible ischemia. So we can suggest an ischemic etiology, but we can't reliably say that colon is infarcted at CT most of the time. Pneumatosis, which tends to be one of our more ominous signs, we still can see in viable bowel, particularly that bubbly type tends to be less ominous. Ultimately, looking for infarction is a surgical diagnosis. The distribution of ischemic colitis, certainly distribution can be helpful to guide us to a diagnosis of ischemia. But there are lots of different potential distributions because it is related to etiology. So in cases of hypoperfusion, hypovolemia, you're looking for abnormalities at the watershed areas between vascular territories. If you had a little embolus or thrombus in a distal branch, you could have random short segments of abnormality. We can have ischemia due to overdistension, so colon obstruction or volvulus can cause ischemia. And for some reason, I'm not even sure what the underlying physiology is, but patients with shock and trauma, you tend to see a predilection for ischemia in the right colon. Also, sparing of the rectum. The rectum has a dual blood supply, so if we see involvement of the rectum in any case of colitis, it is unlikely that it is ischemic colitis. Might be IBD, might be infectious, unlikely to be ischemic. Here, a sort of classic vascular distribution involving the SMA. We've got small bowel, we've got right colon. Transverse colon looks a little bit abnormal too, but by the time we get over to the descending colon, it looks completely normal. So an SMA, SMB distribution. Here, a watershed distribution. So this was a patient, this was actually an interesting case. It was a young patient who was very fit and actually ran a marathon or something on a hot day, and then came in with left-sided pain and bloody stools just from hypovolemia. And look, we have this like very classic sort of uniformly hypodense, crisp outer wall, not stranding or anything. This is the dry appearance of ischemic colitis, and a very good story and very convincing appearance. So at the CT, we were able to just say this is compatible with hypovolemia, ischemic colitis, and did not diff it out as possible infection or anything like that. Here, an example of a colon mass causing obstruction and massive overdistension of the right and transverse colon. And look at that wall, it's very thinned out. This is an example of a thin wall in ischemic colitis. Same with this case of volvulus. And then ascites, in terms of ischemia, not wildly helpful here. It can be present in some cases, absent in others. Not really a useful method from differentiating from infectious causes of colitis, but helps most with those cases of IBD. Okay, so the next topic that we're going to discuss is CT of diverticulitis, kind of a variant of colitis. And I'm going to start with CT signs, talk a little bit about complications, and then a few pitfalls in making the diagnosis. So the most useful signs of diverticulitis, it sounds silly, but the first is the presence of diverticula. So if you don't have diverticula, it's sort of hard to make a confident diagnosis of diverticula. So first look for that. And secondly, you want to look for colon wall edema or wall stratification. And here I'm talking again about that hyperdense layering of the colon wall. different from just colon wall thickening, as we see in this image that just popped up. So you can have colon wall thickening just in muscular hypertrophy that coexists with diverticula in a lot of patients, whether they have inflammation or not. So we're really looking for that edematous appearance of the colon wall as a good sign of diverticulitis. Pericolonic fat stranding or fascial thickening, both good supportive signs of the diagnosis, very common. And then some less common signs of inflammation that we still see in a number of cases and can be helpful: mesenteric free fluid or engorgement of the vasa recta. Now, one of the best signs I find for making a confident diagnosis of diverticulitis is to find a single diverticulum that is definitively inflamed. They can have a number of different appearances. Here, the first sort of thick-walled, hyperemic, some fluid right around it that looks definitively inflamed. The second image, that diverticulum almost looks phlegmonous, but both of these cases, definitively inflamed diverticula, leading to a confident, specific diagnosis of diverticulitis. Here, another nice example of a focal inflamed diverticulum. Not a lot else going on in this colon, but we see a single diverticulum that's hyperemic. The wall is thick. There's adjacent stranding. So with that, we can make a diagnosis of mild acute diverticulitis. Now, the arrowhead sign is something that's reported in the literature as being extremely specific for diverticulitis. This is not something I've seen a lot in clinical practice, maybe in part because I mentioned earlier we don't usually give positive oral contrast with our abdominal pain cases. But what this refers to is essentially contrast extending into the lumen of one of these definitively inflamed diverticula. And the inflamed neck of the diverticulum sort of creates that arrowhead-like appearance. So if you do see this occasionally, this is a very specific sign of diverticulitis at CT. Now, complicated diverticulitis. Why does it matter, and what do I mean by it? Well, it matters because if diverticulitis is uncomplicated, those patients are usually treated as outpatients, usually just with oral antibiotics. If it's complicated, though, that's going to mean an inpatient admission most of the time, for the very least for IV antibiotics, if not some other intervention. So the sorts of things we're looking for to designate a case as complicated is perforation, phlegmon, abscess, peritonitis. So perforation, again with bowel perforation, one of the best signs to make the diagnosis is just to look for free air. Often the amounts of free air are pretty small in perforated diverticulitis, so just these little bubbles next to affected areas of the colon, indicative of microperforation. Abscess, and abscess sort of comes in two flavors. We can either see pericolonic abscess, like in the first case, or a feature that we often will see in diverticulitis, intramural abscess. So as we see in the second case where the arrow just popped up, we see a fluid collection actually within the thickened wall of the colon. Fistulas or sinus tracts, we often see in cases of complicated diverticulitis. It's a little difficult to see what's going on this single image. So I'll point it out, but that is our single inflamed diverticulum with the thick wall, and the structure right in front of it is the bladder, which has a bunch of air in it. The patient did not have a Foley. This is air that's getting into the bladder from a fistula from the sigmoid colon. So acute diverticulitis leading to a colovesicular fistula. Okay, so what are the pitfalls in making a diagnosis of diverticulitis at CT? There are a couple things that can lead to an equivocal case. One is that you've got a patient with tics and the wall looks a little bit thick, but there is no definite acute inflammation. So is this just muscular hypertrophy? Could it be mild acute diverticulitis? Or you have areas where the wall is very thick and maybe it's not a long segment, maybe it's sort of focal, and there it can be difficult to differentiate from colon cancer. So in terms of those cases where you see some wall thickening and you see some tics and you're just not seeing a lot of inflammation, and maybe there's a suggestive history, left lower quadrant pain, fever, and the case looks something like this, sometimes these patients will actually turn out to have diverticulitis, and we can miss some cases that there's just sort of intramural inflammation and there's not a lot of stranding and so on and so forth yet. So I actually have a pretty low threshold for calling mild, acute, uncomplicated diverticulitis, because this isn't something like where you overcall appendicitis or something and they're going to the OR. This is like, you overcall it a bit and, they're getting some antibiotics and going home. So I tend to have a high index of suspicion in the appropriate clinical setting. Here, the other type of equivocal case where the colon wall is quite thick and it's a fairly short segment of involvement, and the ticks aren't actually terribly obvious on this particular slice, but there were ticks. And was this a case of sort of focal diverticulitis, or could this be colon cancer? So there's actually a whole sort of body of literature on this, that if you sort of look at the different features we can see at CT, some are much more suggestive of diverticulitis and some are much more suggestive of colon cancer. So this is sort of our list of features that suggest diverticulitis. So a long segment of disease, greater than 10 centimeters. Seen fat stranding, seen mesenteric fluid, seen vascular engorgement, that arrowhead sign, that single inflamed diverticulum. We've talked about all of those signs. And then one more that we haven't talked about yet, preserved enhancement pattern of the bowel wall. So let me explain what I mean by that before we go on. So preserved enhancement pattern of the colon wall refers to sort of seeing that stratified appearance, that edematous appearance through the whole area of abnormality without interruption of that edematous stratified appearance. So like we see here, the colon is thick here, but we can see that stratified hypodense inner layer appearance throughout the abnormal segment. I want to contrast that with this case, where here you're seeing hyperdense, hypodense, hyperdense, that sort of stratified look coming down, and then boom, it's interrupted quite abruptly by this enhancing mass. This was a case of cancer. So if you look at all of these features that are suggestive of diverticulitis, it turns out that two of them are much better than the others for making an accurate diagnosis of diverticulitis versus colon cancer, and they are these two. So a single inflamed diverticulum, being able to point to one diverticulum and say that diverticulum is definitively inflamed, and seeing that preserved enhancement pattern of the bowel wall, those are the two best signs for differentiating diverticulitis from colon cancer. Now, conversely, there are some other signs which suggest colon cancer. Those are the presence of mesenteric lymph nodes. And you might think that, diverticulitis is inflammatory, there might be reactive nodes. But if you see nodes, it is much more likely to be colon cancer than it is to be reactive nodes from diverticulitis. So that's a warning sign. Obviously, if you see a luminal mass, we want to be concerned about colon cancer. Again, that interruption of the enhancement pattern of the bowel wall, highly suggestive of cancer. And obstruction. So if you see something that looks like diverticulitis, but there is colon obstruction present, it is 3 times more likely that you're looking at cancer than you're looking at diverticulitis. You can sometimes have obstruction and diverticulitis, but it is rare compared to cases of cancer. So obstruction is a worrisome sign. So still, using all of these imaging features, definitive diagnosis is only possible in about 50% of cases. That said, a definitive diagnosis is possible in about 50% of cases. So I don't believe that, every time you call a case of diverticulitis, you have to, say follow-up colonoscopy or so on and so forth. There are cases that are definitive and you can call them definitively. There are some where we cannot be so definitive. There is considerable overlap in the spectrum of appearances. So let's take a look at some examples. Here we've got some colon wall thickening. We certainly have some pericolonic fat stranding denoted by the arrows here. I'm sort of thinking could be diverticulitis at this point, but these are further images in this patient. And here we're starting to see something that looks like lymphadenopathy, big lymphadenopathy, and actually an enhancing luminal mass. So this is definitively colon cancer. What about this one? So we've got we have ticks. Okay, so step one. We've got a relatively long segment of involvement. So both of those features could point towards diverticulitis. But this is another image in the same patient. This colon also looks at least mildly obstructed. This colon is quite dilated, proximal to that abnormality. So just seeing that, even though we didn't see a luminal mass or nodes or anything like that, obstruction is a warning sign, and this patient turned out to have colon cancer. Another one, so a sort of focal abnormality here. So, we're worried, could it be cancer? We do see ticks. We see wall thickening. Looks reasonably stratified, so that's a good sign. And then on that last image, we see a single diverticulum that looks definitively inflamed. That is an excellent sign for diverticulitis. And although this ended up being short segment, this was diverticulitis. So I've brought up the issue of colonoscopy. When is it necessary? When isn't it necessary? It's actually kind of controversial. Post-diverticulitis colonoscopy shows a prevalence of colon cancer between 0 and 2%. If you just do colonoscopy in the average population over age 55, it's in that same range. It's about 0.7%. So basically, it doesn't seem like we're picking up a lot of additional colon cancers by doing a colonoscopy in every patient who has a CT diagnosis of diverticulitis. But most studies do agree that the likelihood of an underlying cancer is far higher in complicated cases. So if you have perforation, if you have intramural abscess or pericolonic abscess, if you have fistula, all of these factors push the likelihood of colon cancer up. So any complicated case of diverticulitis should get a follow-up colonoscopy. So to summarize, the take-home points for CT of the colon. For IBD, you're wanting to look for acute and chronic inflammation in the same patient at the same time. And oftentimes, these patients will have no ascites despite pretty severe colonic inflammation. And that is a good hint as to what's going on. For infection, oftentimes it can be nonspecific. Distribution can be the most helpful. For ischemic, you're looking for bowel distension, pore enhancement, like that dry appearance of ischemic colitis, pneumatosis, or some sort of characteristic vascular or watershed distribution. And for diverticulitis, the best two signs to differentiate from colon cancer are a single inflamed diverticulum and uninterrupted bowel wall edematous stratification. Thank you very much.